Spina bifida and fetal intervention. Spina bifida is one of many types of congenital anomalies that can occur as a result of the problems with early development of a fetus. Every year, about 1,500 to 2,000 children are born in the United States with spina bifida. The tissue that covers the spinal cord closes like a zipper early in fetal life. It is completely closed by day 25 of pregnancy, 2 weeks after a woman misses her next expected menstrual period. If the tissue fails to close at the top end, this produces a problem in the fetus known as anencephaly. Failure of closure at the bottom end of the fetus results in spina bifida, as illustrated on the right-hand side of this slide. A case of spina bifida is shown here. Typically, the protruding sac contains both fluid and nerve tissue. This is called a myelomeningocele. If the sac contains only fluid, this is called a meningocele. Both of these types of spina bifida are known as open neural tube defects. A closed neural tube defect is one that is covered by skin. Spina bifida can occur at any location on the fetal spine. The upper region is called the cervical spine. This is located in the fetal neck and is composed of 7 separate bones called vertebrae. The chest portion of the spine is called the thoracic spine and is composed of 12 vertebrae. The lower back is called the lumbar spine and is composed of 5 vertebrae. Finally, the lowest region of the spine is composed of 5 sacral vertebrae. In the adult, these 5 bones become fused together into one structure called the sacrum. However, in the fetus, these remain as separate bones. Spina bifida is usually described as the type, meningocele or myelomeningocele, and the level of the opening. As an example, the most common type of spina bifida would be an L2 to S2 myelomeningocele. This means that the opening of the spine starts at the middle of the lumbar spine and extends about halfway down the lower back of the fetus. The level where the spinal canal is open, called the level of the bony defect, is somewhat predictive of the subsequent neurologic or nerve problems that a child will experience. However, 2 children with the same level of bony defect may show slightly different effects. There are, however, different patterns of nerve damage based on the level of the spinal cord lesion. The colors in this picture represent the areas in the lower body and leg where the various spinal nerves are connected to allow an individual to detect, touch, or heat. As an example, an L4 to S3 lesion would involve loss of sensation on the front side of the body in the light blue, pink, purple, and tan areas. These same areas would lack sensation on the back of the body. The spinal nerves that are involved in the spina bifida are also associated with problems with motor function. This picture illustrates the various nerve levels involved in moving the lower leg. Moving the thigh forward involves spinal levels L2 and L3, while moving the thigh backward involves spinal levels L4 through L5. Spinal levels L3 and L4 allow the knee to be moved forward, while levels L5 to S1 are involved in moving the knee backward. Finally, this picture depicts the spinal levels involved in moving the ankle. Spinal levels L4 and L5 allow one to raise the foot, while levels S1 and S2 allow one to lower the foot. In general, when the spina bifida involves a level above L3, the chance for walking is poor. If we use our example case of L4 to S3 spina bifida, one can see that there will be some ability to move the thigh back and forth, but movement of the knee and ankle will be less likely. Since many cases of spina bifida involve the sacral nerve roots S2 through S5, children with spina bifida often have problems with urination and bowel control. The usual bladder problem is retention of urine. This is usually treated by placing a small plastic tube in and out of the bladder called intermittent catheterization on a daily schedule. As the child gets older, he or she can be taught to do this themselves. Children with spina bifida may also have problems with incontinence or leakage of fluid. This is because they cannot tell when their bladder is full. Problems with bowel control are usually related to soiling. Females with spina bifida do not experience orgasm but can become pregnant and deliver naturally. Males with spina bifida have problems achieving an erection. However, there are medical means to allow this to occur. In addition, the production of sperm is normal, and with special methods, these children can father a child. Spina bifida is associated with two other problems that are a side effect of the spinal defect. The first is called hydrocephalus. This figure illustrates a normal cross-section of the brain. The cerebrum is the gray matter of the brain. Inside are two compartments called the ventricles that contain fluid that is constantly being made by special tissues in the brain. This is called cerebral spinal fluid, or CSF for short. Normally, CSF fluid flows around the back of the brain, called the cerebellum and brainstem, into the spinal canal to surround the spinal cord all the way to its bottom end. In the case of spina bifida, the herniated nerve tissue at the base of the spine pulls the brain downward into the base of the baby's skull in what is called a Chiari-II malformation. This blocks the normal flow of cerebral spinal fluid and causes the ventricles to become enlarged, a condition known as hydrocephalus. This picture is taken by special imaging equipment called magnetic resonant imaging, or MRI. This is an image of a normal brain in a newborn infant. The red line indicates the top of the spinal canal. Note, there is no evidence of brain tissue located below the line. The red arrow is pointing to the ventricle of the brain that contains a normal amount of cerebral spinal fluid. Since there is no Chiari-II malformation here, cerebral spinal fluid can flow freely down the spinal column. This MRI image is from a newborn with a Chiari-II malformation. Note that some of the back of the brain protrudes downward below the red line. The red arrow marks the brainstem, and the black arrow marks the cerebellum. The red star is located in the cerebral ventricle, which is markedly dilated. This is called hydrocephalus. The Chiari-II malformation shown here is associated with compression of certain parts of the brain that control swallowing and breathing. For this reason, approximately 10% of children with spina bifida and the associated Chiari-II malformation may die at some time in their lives due to complications of aspiration or decreased breathing. Hydrocephalus can be treated with the placement of a specialized shunt soon after birth. This is called a ventriculoperitoneal, or VP shunt. Placement of the shunt involves a surgery where an incision is made into the top of the baby's skull with placement of the tube into the ventricle with the excess cerebral spinal fluid. The tube is then tunneled under the skin, and a second incision is made to place the other end of the tube into the peritoneal cavity, or belly. When the pressure in the ventricle builds to a certain level, a valve allows the fluid to escape from the ventricle into the baby's peritoneal cavity, where it is naturally absorbed. Unfortunately, shunts are mechanical devices, and they sometimes fail due to blockage or movement and must be replaced. Shunts can also become infected, and then they must be removed. A baby with spina bifida will on average have approximately 3 to 6 shunt revisions in his or her lifetime. In the past, most cases of spina bifida were detected by drawing a blood sample from the pregnant patient between 16 and 18 weeks of gestation to measure the level of alpha-fetoprotein, or AFP. This protein is found in very high levels in the fluid that surrounds the fetal spine. An elevated level in the mother's bloodstream meant that cerebral spinal fluid was leaking from the spina bifida into the amniotic fluid, and that this was then leaking into the maternal bloodstream. The next step in the diagnostic process involved amniocentesis to check for the level of alpha-fetoprotein in the amniotic fluid. A second protein called acetylcholinesterase was also measured. An elevation of the alpha-fetoprotein and the acetylcholinesterase indicated that an open spina bifida was likely in the fetus. Today, most patients undergo an ultrasound at 16 to 20 weeks of pregnancy, or 4 or 5 months, to check for any evidence of birth defects. This is when most cases of spina bifida are detected. Several important features can be seen when an ultrasound of the fetal head is undertaken in a fetus with suspected spina bifida. The first is called the lemon sign. These findings can be seen in this image. The red arrows point to the indentions in the soft fetal skull bones as a result of the back of the fetal brain being pulled down into the spinal column, the Chiari-II malformation mentioned earlier. These indentions resolve later in pregnancy as the fetal skull becomes more calcified. This next image illustrates the normal structures at the back of the fetal brain. The white outline indicates the shape of the normal fetal cerebellum. The yellow arrow indicates the normal space seen behind the cerebellum and the back of the baby's skull. This is called the cisterna magna. Notice that the cerebellum is dumbbell-shaped. This image illustrates the Chiari-2 malformation. The white line outlines a cerebellum that is banana-shaped. There is no cisterna magna space visible behind the cerebellum as indicated by the yellow arrow. The cerebellum is shaped like a banana due to the fact that it is being pulled backward into the spinal column, the Chiari-2 malformation. Today, ultrasound is more than 98% accurate in detecting spina bifida. In the top left panel, one can see a cross-section of the fetus at the level of the lower spine. This would be like looking at one slice of a loaf of bread. The bony parts of the spine are splayed apart as indicated by the red arrows. One can also see the fluid-filled sac of the myelomeningocele as illustrated by the white circle. The white arrows in the picture on the right panel indicate the splaying of the spine in a long view of the fetus. Newer ultrasound technology called 3D ultrasound also allows for a better view of the fetus. Here one sees a normal spine in long view. In this image, one can see the myelomeningocele on the surface of the fetus as indicated by the red circle. An ultrasound of the fetal head can also detect the amount of fluid in the two main chambers in the brain called the fetal ventricles. In this image, the red arrows point to the walls of a normal-sized ventricle. In this second image, the yellow arrows point to the size of a very enlarged lateral ventricle, demonstrating hydrocephalus. The ventricles on either side of the brain are usually dilated equally. However, in some cases they can be different sizes. Normal-sized ventricles usually measure less than 10 millimeters in width. If they measure greater than 10 millimeters but less than 15 millimeters, this is called ventriculomegaly. Ventricles that measure more than 15 millimeters in width are called hydrocephaly. In 1994, surgeons at Vanderbilt University attempted to close spina bifida in 4 human fetuses using a skin graft from the mother and inserting it into the uterus through a specialized telescope called a laparoscope. Unfortunately, their efforts did not prove successful, as 2 of the 4 fetuses died due to complications of the procedure. 4 years later, these same surgeons reported on 4 additional cases using an incision in the mother's uterus to obtain better exposure to the fetus. Despite premature deliveries of these pregnancies, all 4 infants showed reversal of the Chiari-2 malformation that had been detected during their fetal life. In addition, only 2 of the 4 fetuses required a ventricular shunt at all. Enthusiasm for the in utero repair of spina bifida subsequently led to 4 medical centers performing over 250 fetal spina bifida repairs. Unfortunately, the outcomes of these children were mixed, and the only comparison group available to determine if the treatment was indeed effective were other children that had not undergone repair after birth at these centers in the distant past. The National Institutes of Health convened a conference, and the scientists and fetal surgeons decided the best course of action was to conduct a randomized clinical trial. In this way, half of the fetuses, a flip of the coin, would undergo the in utero repair of their spina bifida, and half of the fetuses would be repaired as neonates in the standard fashion after birth by the very same neurosurgeons. The results would then be conclusive as to whether fetal repair was more effective than waiting until after birth to do the repair. In February of 2003, the National Institutes of Health began the Management of Myelomeningocele Study, also known as the MOMS trial. 200 patients were to be randomized, half to fetal repair and half to repair after birth. 3 centers, Vanderbilt University in Nashville, Tennessee, Children's Hospital of Philadelphia in Pennsylvania, and the University of San Francisco in California, provided the surgery for these patients. The trial took almost 8 years to complete and cost taxpayers over $20 million. Over 1,000 patients were initially screened for the study. 530 of these were excluded for a variety of reasons, leaving 299 patients that were sent to one of the 3 surgical centers. After additional diagnostic studies, 75 additional patients were excluded, leaving 183 patients that were randomized, 92 to the repair group after birth, and 91 in the fetal repair group. The study was stopped in December of 2010 when the committee that was monitoring the results of the study noted on the 4th look at the outcomes data, called an interim analysis, that there was a clear benefit to fetal repair. The study results were made public in early February of 2011 and were released in the form of a scientific article in the New England Journal of Medicine in March of 2011. For patients to be eligible for the MOMS trial, they had to meet certain maternal and fetal requirements. The pregnancy had to be associated with a single fetus between 19 and 25 completed weeks of gestation. Pregnancies with twins were excluded since a normal twin would be put at higher risk for premature delivery by the surgery. The gestational age limits were chosen based on the previous experience at the surgical centers from cases of spina bifida repair performed prior to the MOMS trial. The mother had to be more than 18 years of age. Her body mass index, or BMI, had to be less than 35. This is a calculated number based on maternal weight and height. A BMI of greater than 35 is considered to indicate significant obesity and would make the fetal repair difficult and more risky to the mother. A history of a previous incision in the uterus, such as a classical C-section, was felt to be a contraindication to fetal repair, since this history already puts the pregnant patient at risk for scar separation late in pregnancy. The investigators felt that making a second risky scar in the uterus for the fetal repair might place the pregnancy at a higher risk for loss. Finally, a short cervix measuring with vaginal ultrasound in the current pregnancy, or a history of premature delivery of a previous pregnancy, were contraindications to enter the trial because patients undergoing fetal spina bifida repair are already at increased risk for premature delivery due to the uterine incision made during the pregnancy. Additional risk factors that prevented a woman from being offered the intervention were insulin-dependent diabetes, infection with hepatitis B or C, HIV infection, red cell alloimmunization, and unwillingness to accept blood for religious reasons. Fetal conditions that allowed a patient to enter the MOMS trial included the presence of a myelomeningocele located between the first thoracic vertebra, or T1, and the first sacral vertebra, or S1. There could be no evidence of kyphosis, a curved spine. The fetal spina bifida could not be associated with other fetal anomalies, such as a heart defect. Finally, the fetus had to have normal chromosomes by amniocentesis. There were 2 main outcomes of the study. The first was the death or need for a VP shunt by 1 year of age. The designers of the trial felt that if the children did not receive a shunt by 1 year of age, they were not likely to need a shunt during their lifetime. The second main outcome of the study was to measure the mental and motor development using standardized tests at 30 months of age. Depicted in this table is a distribution of the level of the spina bifida lesions in the study. As one can see, the great majority of the defects were located in the upper to mid-lumbar region of the fetus. The data from the MOMS trial indicated significant risks to the mother that are associated with in utero repair of spina bifida. Even though the fetal membranes are stapled to the wall of the woman when the incision is made, 1 in 4 patients were noted to have separation of the membranes from the wall after the surgery. This finding is a known risk factor for rupture of the membranes. This occurred in almost half of the patients after in utero repair and was 6 times more likely to occur than when the spina bifida repair was postponed until after the delivery of the baby. Both pulmonary edema, fluid on the mother's lungs, and abruption, premature separation of the placenta, often leading to early delivery, occurred more often in the fetal surgery group. Infection rates were comparable in the 2 groups. The risk for a decreased amount of amniotic fluid around the fetus, also known as oligohydramnios, was 5 times as likely to occur in the fetal surgery group, probably as a result of leakage of fluid through the surgical incision. Most importantly, when the obstetricians looked at the time of C-section delivery at the uterine incision that had been used for the fetal spina bifida repair earlier in pregnancy, they found that the scar was very thin in 1 out of 4 cases, and there was evidence of scar separation in an additional 10% of cases. The finding of a thin scar at the time of delivery in those patients that underwent fetal repair spina bifida has very important implications for the patient's next pregnancy. A recent study has been published from the cases that underwent fetal surgery between 1996 and 2007 at the Children's Hospital of Philadelphia. The study showed 47 pregnancies that underwent both maternal fetal surgery for the repair of a variety of fetal problems. 2/3 of the patients had open surgery for the repair of spina bifida prior to the start of the mom's trial. In their next pregnancy, 14% of the patients were found to have partial separation of the previous fetal surgery scar, and an additional 14% had complete separation of the scar. Although there were no fetal or newborn deaths reported in this series, rupture of the uterine scar is known to be associated with a significant blood loss in the mother and fetal distress and brain damage in the fetus. Fetal repair spina bifida was also associated with significantly increased risk for the newborn. The average gestational age at delivery was about 3 weeks earlier in the fetal surgery group, 34.1 weeks versus 37.3 weeks. 13% of babies were delivered before 30 weeks of gestation. An additional 1/3 were delivered between 30 and 34 weeks, and another 1/3 were delivered between 35 and 36 weeks. This means that only 1 in 5 babies were delivered at term after fetal surgery. Birth weight in the fetal surgery group was about 1.5 pounds less than the group that had post-delivery repair. Although there were no infant deaths in either group, the increased rate of prematurity in the fetal surgery group was also associated with a 21% incidence of respiratory distress syndrome, requiring oxygen and ventilator support in these babies. There was 3 times higher rate of postnatal repair group. Other complications in the nursery included necrotizing enterocolitis, an infection of the bowel, periventricular leukomalacia, abnormal brain finding associated with cerebral palsy, and overall sepsis, infection in the blood, were not increased in the fetal surgery group. Since open fetal surgery for spina bifida is typically performed between 22 and 26 weeks of gestation, if a premature delivery was to occur after the procedure, there can be severe consequences for the newborn. This graph shows national data indicating that the rate of survival at 23 weeks gestation is about 30%, increasing to 92% by 28 weeks. This graph shows the chance of developing severe neurologic complications such as mental retardation, cerebral palsy, blindness, and deafness in those children that do survive. The chance of neurologic problems decreases from about 55% of infants born at 23 weeks to about 18% when an infant is born at 28 weeks. The benefits of fetal repair spina bifida appear to be statistically superior to postnatal repair. The primary outcome of the study, death or the need for VP shunt in the first year of life, was 30% less frequent in the fetal repair group. In the fetal repair group, 1 fetus died soon after in utero surgery, and a second died in the nursery after a premature delivery at 23 weeks gestation. There were 2 deaths in the first year of life in the postnatal repair group due to complications of their spina bifida. The major differences in the 2 groups appeared to be related to the resolution of the Chiari-2 malformation and the resulting hydrocephalus in the fetal repair group. Babies that underwent fetal repair were half as likely to ever need a VP shunt, 40% versus 82%. All fetuses that were entered in the study had had evidence of hindbrain herniation on MRI during their mother's pregnancy. The Chiari malformation was found to be less common in the fetal repair group as compared to the postnatal repair. Both herniation and kinking, when present, were of a milder degree in the fetal repair group. Bailey scores, a standardized measurement of an infant's performance, were similar for mental development in both groups. However, Bailey scores for motor development were superior in the fetal surgery group. Motor function in the baby's lower extremities was 2 levels higher than where the spina bifida was located in almost 1/3 of the fetal surgery children. Twice as many children who underwent in utero repair were walking independently as compared to the postnatal group, 42% versus 21%. Walking without braces was also twice as common in the fetal surgery children. The WeFem score is a measurement of the degree of disability in a child. Higher scores are associated with less disability. In the fetal surgery group, scores for self-care and mobility were higher than the postnatal surgery children. Cognitive scores were similar. Although the MOMS trial was a well-designed clinical trial, it only lets us quote overall statistics for the benefits of fetal intervention over postnatal repair of spina bifida. Most parents will ask, how will their baby turn out if they decide to have the surgery? Unfortunately, there is no way to answer this question. How will my baby be managed if there is a planned repair of my baby after it is born? We would manage your pregnancy in the same fashion as was the case before fetal intervention was available. A nurse coordinator would be assigned to your case. A comprehensive ultrasound and MRI would be scheduled to assess the level of the spina bifida. Meetings would be scheduled with a spina bifida specialist, a pediatric neurosurgeon, and a neonatologist before your baby is born. The remainder of your routine prenatal care in this pregnancy can be handled in one of 2 ways. If you choose to continue your care with your primary OB provider and you are planning to deliver at Children's Memorial Hermann Hospital, we would ask that our general OB-GYNs at UT see you for a prenatal visit by 32 weeks of gestation. This is a meet and greet visit where you would talk with the doctor that would do your delivery, and your prenatal records would be reviewed to be sure that all was in order. You could then continue the remainder of your care until around 37 to 38 weeks, when we would ask you to once again see our UT OB-GYNs to schedule your delivery. Alternatively, if you and your OB provider decided it is in your best interest to transfer your care to our department, the generalist OB-GYN doctors at UT would provide your prenatal care and would deliver you. In any event, you should have serial ultrasounds every 3 to 4 weeks throughout the remainder of the pregnancy to be sure that all is well with your developing fetus. At 38 to 39 weeks, you will be scheduled for delivery by elective C-section. This is chosen as a route of delivery since some studies show that delivering a baby with spina bifida before the onset of labor actually improves our motor function slightly. Undergoing fetal intervention for your baby is a major commitment to a lifestyle change for the rest of this pregnancy. It includes a 5-day hospitalization for the initial surgery, 3 weeks of strict bed rest after the procedure, and weekly ultrasounds to monitor fetus and assess for complications of the surgery. More importantly, there may be prolonged subsequent hospitalizations in this pregnancy if complications should arise, such as membrane separation, premature labor, or leakage of amniotic fluid. Many mothers with small children find this commitment difficult to consider. Before fetal intervention can be considered further, thorough counseling and evaluation must be undertaken to be sure that there are no risks to the mother and that the fetus is an appropriate candidate for in utero surgery. You will start out your day with a meeting with a specialized pediatrician who is in charge of the spina bifida clinic at Shriners Hospital to go over the basic issues related to spina bifida. Next, there will be a comprehensive ultrasound not only to assess for the presence of the Chiari-2 malformation, but to determine the level of the spinal cord lesion. After a visit with a genetic counselor, an amniocentesis will be performed to be sure the fetal chromosomes are normal. A FISH test can give rapid initial results in 36 hours for most major chromosomal problems, but the final analysis requires 10 days to 2 weeks. A maternal history and physical will be undertaken by the maternal fetal medicine specialists. The results of the comprehensive ultrasound will be reviewed with you. If you are not deemed to be an appropriate candidate, the evaluation process will stop at this point. Early in the evaluation process, you will have met with the nurse coordinator that is assigned to be your case manager. She will meet with you again on the second day of the visit. You will undergo a magnetic resonance imaging test, or MRI. This test is like a CAT scan, but uses magnetic waves to look at the fetus for birth defects. The magnetic waves are safe for you and your baby. You will then undergo a fetal echocardiogram, a specialized ultrasound of the baby's heart to look for problems. You will meet with a social worker to review your family, friend, and church support systems for undertaking the fetal intervention. You will meet with a pediatric neurosurgeon who will be doing the in-utero repair of the baby's spina bifida. A neonatologist will talk with you about the complications in the baby of a premature birth that could result secondary to the fetal surgery. There will be a brief meeting with a financial counselor to be sure that all insurance verifications and other payment issues are addressed in advance. If you have other small children at home, we will offer to have you meet with a child life specialist from Children's Memorial Hermann Hospital. This individual will help you explain your unborn baby surgery to your other children. Finally, at the end of a long day, you will meet with the maternal fetal medicine specialist who will be involved in your surgery. This person will go over the actual procedure and answer any questions that you may still have. Once you decide to have fetal surgery for spina bifida, your case will be presented to a special oversight committee of experts to be sure that the surgery is still a good option for both you and your unborn child. Should you elect to proceed with fetal intervention, your surgery will typically be scheduled between 22 and 26 weeks of gestation. You will be asked to come to the hospital early in the morning of surgery. A plastic tube will be placed in a vein in your arm, and blood will be drawn. Antibiotics and an antacid will be given as medications through your IV. You will also be asked to drink a bitter-tasting antacid to neutralize any remaining acid in your stomach. Finally, a suppository of a medication called indomethacin will be placed by the nurse. This medicine is given to help prevent contractions during the surgery. A special pumping device with stockings will be placed on your legs to help prevent blood clots. Then you'll be taken to the operating room on a stretcher. Typically, the surgery will last about 3 hours. Once the abdomen is opened, ultrasound is used to locate the placenta inside the womb. The placenta must be avoided during the time of the incision so as to prevent bleeding complications, since it provides both oxygen and nutrients to the fetus. If the placenta is on the front side of the uterus, the incision to gain access to the fetus may have to be made in an unusual location, such as on the back side of the uterus. A special stapler is used to open the womb. The stapler allows the womb to be open while keeping the edges of the uterine muscle from bleeding. The staples are dissolvable and will disappear over several months after the surgery. This photo shows a stapler being used to create the incision in the womb. Once the stapler has been fired and the device removed, the edges of the womb are sealed and there is no blood loss. Here one can see the back of the fetus inside of the womb, as illustrated by the black arrow. Here one sees a diagram for the surgical repair of the spina bifida. The black arrows point to the staple lines at the edges of the opening in the uterus. Neurosurgeons are closing the thick covering of the spinal canal, called the dura mater, over the neural placode or fetal spinal cord. They will then attempt to cover the defect with a second layer of fetal muscle and skin. After the fetal repair is completed, the womb is closed and sterile fluid is replaced to restore the amniotic fluid to its original volume. The patient is then transported to labor and delivery for intensive fetal and uterine monitoring to prevent premature labor. Once your surgery is over, you will be taken by a stretcher to labor and delivery, where you will receive nursing care from one nurse each shift. You may notice a slight sore throat. This is a result of the breathing tube that was placed in your windpipe to help you breathe during the surgery. You will also notice a few new things that were added while you were asleep in the operating room. A second IV will be in your other arm from where the first one was placed earlier in the day. There will be a small plastic tube in the artery in your wrist. This is called an arterial line and is used to continuously measure your blood pressure. Blood samples can also be taken from this line without having to do another skin puncture. There will be a plastic device around one of your fingers called a pulse oximeter. This is used to measure the amount of oxygen in your blood. There will be a catheter in your bladder so that you will not have to get up to urinate. There will be a plastic dressing over the surgical incision in your lower abdomen. This type of dressing is used so that ultrasound can be performed through it to assess your fetus. The epidural that was placed when you first arrived to the operating room will be used during the first 2 days for pain relief after surgery. You'll be given a button to push to deliver the medication through the tube in your back to bathe the pain nerves. This medication is safe for your unborn baby. Your nurse will instruct you on the use of a plastic device that is connected to a tube for you to blow in. This device is called an inspirometer. It is used to help you take deep breaths after surgery to reopen the small air spaces that may collapse after you've been put to sleep. The use of the inspirometer will help prevent fever after surgery that can result from the collapse of these small air pockets. A belt will be placed over your uterus to check for contractions. This will remain in place for the next 2 days of your stay because premature contractions are the main complication of in utero surgery. Your nurse will listen to your baby's heartbeat every 4 hours. Finally, the pumping stockings that have been placed before your surgery will continuously inflate and deflate to prevent blood clots from forming in your legs while you are at bed rest. The first day you are back from surgery will be your hardest. You will be asked to stay in bed. You will not be allowed to drink or eat. Probably the hardest part of the day will be the way that you will feel due to a medication called magnesium sulfate that will be used to help prevent uterine contractions. Many patients describe losing one day when they are on this drip. You may feel hot and flushed and like you are in a daze. These are all normal symptoms from magnesium sulfate that are not dangerous to you or your baby. A second medication will be given by the nurse as a suppository in your rectum every 6 hours to also prevent uterine contractions. On the first day after surgery, things will start to get better in your recovery. You'll be allowed to have ice chips by mouth at noon, and if your stomach handles these, you'll be given clear liquids for supper. An ultrasound will be performed at the bedside to look at your baby and check the fluid around it. The arterial line and the second IV will be removed. The magnesium sulfate drip will be stopped, and you'll begin to feel more like yourself. A new medication called nifedipine will be started by mouth. This medication can cause headaches and low blood pressure, but the nursing staff will be watching for these side effects. The rectal suppositories will be stopped, and the indomethacin will instead be given by mouth for the next 24 hours. On the second day after surgery, your road to recovery will be more rapid. The epidural catheter will be removed from your back, and you'll be switched to pain medications by mouth. You'll be given a regular diet for breakfast. The catheter will be removed from your bladder. The IV will be removed from your arm. You will then be moved to a private room on the floor where undelivered pregnant patients are being watched. There you'll be allowed to take a shower in a chair. The belt that has been over your uterus during the past 2 days will only be placed for 30 minutes every 8 hours. If you feel that you're experiencing cramps or a tightening of your womb between the times that you are scheduled to be on the monitor, you should notify your nurse immediately so that they can reapply the belt to look for contractions. You'll be asked to continue to wear the pumping stockings when you're in bed to prevent blood clots. On the third day after surgery, you should be feeling much more like yourself. You'll be allowed short walks with the assistance of a nurse or family member. You'll be asked to wear the pumper stockings when you're in bed or sleeping. If there have been no complications of surgery, you can plan on being discharged in the morning of the fourth day after surgery. You'll be asked to make plans for going home to strict bed rest for the next 3 weeks. This will mean that you may get up to take a shower, but you will not be able to cook or shop for your family. You will not be able to drive yourself to doctor's appointments. You should plan on having help at home with small children. You will be given a prescription for pain medications for the next few days. You will also be given a prescription for nifedipine, the medication that is used to keep uterine contractions from returning. You should plan on getting these prescriptions filled as soon as you get home so that you can start these medications. You will also be given an appointment for your first of weekly ultrasounds to be performed. You should plan on coming up to the clinic by wheelchair once the person driving your car can drop you off at the valet parking entrance. After you're sent home, you will be given instructions to call for several things. If you begin to experience uterine contractions, you must call the entrance service immediately. If you do not receive a call back within 30 minutes, we would recommend that you go to the obstetrical triage area at Children's Memorial Hospital and have them call a physician. Since the fetal membranes around the sac containing the baby were entered during the surgery, there is a significant risk that this opening that was made at surgery can cause you to begin to leak amniotic fluid. You will notice this as fluid that keeps coming out of the vagina, especially when you first stand up. This is a serious complication of the surgery, as it can lead to infection with dire consequences for both you and your unborn baby. Again, if this should occur, you should contact your physician immediately. If leakage of fluid is confirmed, you will probably be in the hospital the remainder of the pregnancy to watch for infection. You will be treated with antibiotics and will be given steroids to help the baby's lungs mature. Bleeding from the vagina may be a sign of abruption, a critical situation where the placenta is becoming dislodged from the uterine wall. Again, this can have serious consequences for both you and your baby. You should call your physician. Finally, you'll be asked to check your temperature in the afternoon for several days after you've been discharged from the hospital. If you run a fever of more than 100 degrees by mouth, you should call your physician. During your weekly ultrasounds, the fetal membranes may be noted to have become separated from the uterine wall where they were being held in place by the staples that we used during your surgery. This is called a chorion-amnion separation. It is associated with a high rate of leakage of amniotic fluid. For this reason, if membrane separation is detected by ultrasound, you will be admitted to the hospital for observation for the remainder of the pregnancy. In about 20% of cases in the MOMS trial, patients experienced no complications and underwent a scheduled delivery by C-section at 37 weeks gestation. Even though your due date is 3 weeks further from this time, it is felt that a delivery at 37 weeks is relatively safe for your baby. 37 weeks is also picked as a time for delivery to keep the fresh scar from your fetal surgery from stretching too much as the uterus gets bigger, and to prevent the scar from tearing with uterine contractions. In some cases, your physician may feel it necessary to perform an amniocentesis to check laboratory tests to be sure the baby's lungs are mature. If they are not, steroids could be given to speed up this process before delivery. Finally, your baby will probably be taken to the neonatal intensive care unit soon after it is born for its initial assessment. Although the multidisciplinary team performs a comprehensive evaluation and counseling session, some questions regarding patient experiences just cannot be explained by medical professionals. At the center, many patients and families that have undergone the process are willing and eager to share their experiences of undergoing fetal surgery and life at home afterwards, including those that have undergone fetal intervention for spina bifida. Many children with spina bifida go on to lead productive lives. These children typically have normal intelligence and can overcome their issues with ambulation through the use of various assistance devices. Here we have included a few web-based resources for your information. A copy of these will be given to you. It is our hope that you and your family have found this PowerPoint presentation to be useful in the educational process of learning about spina bifida and the options for fetal intervention. Please feel free to give us feedback so that we can improve our process. Thank you.